Hello, everybody, and welcome back. We are continuing our discussion on heart failure. We introduced the concept of heart failure as kind of an overarching when someone goes into heart failure, they have reduced cardiac output. The causes can be diverse, right? It can be something within the heart, it could be something outside of the heart. It could affect the right side of the heart or the left side of the heart. It could affect the heart during systole when it's pumping or during diastole when it's filling. Heart failure can be life threatening when it's acute and extremely chronic, lasting for years, and people are community dwelling with heart failure. There's a wide range of heart failure, but they all come down to reduced cardiac output. At the end of the last lecture, we went through the symptoms of heart failure, and we talked about how if you can't pump the blood forward because there's a reduced cardiac output with heart failure, fluid backs up in the system behind it. So a lot of the symptoms of heart failure are the symptoms related to the fluid that backs up behind the heart and causes the congestion, which gives the name congestive heart failure. Then we also have the symptoms related to the inability to pump enough blood forward, and how that might manifest itself as muscle fatigue and increased shortness of breath because you can't get enough oxygen delivered to the periphery. And then we ended on this slide at the last recording. And this slide is here and this next discussion is here because your body, when it starts to experience heart failure, when there is a reduced cardiac output, the physiology of your body tries to fix this problem. So we call these the heart failure compensations. It's the way in which people can walk around for years in heart failure because we have a whole host of ways to compensate for reduced heart failure. So all the stuff that you see in the slide that we're about to talk about, because I just want to put this in the back of your mind. In the very beginning, I talked about how serious and life-threatening acute heart failure is. Acute heart failure, when it comes on very suddenly, doesn't give the body the time for all of these compensations. When the reduced cardiac output happens slowly and it gets worse over time, the body has time to kind of tap in to some of its compensatory mechanisms. Now, I want to say this up front. So as we introduced each one of these, you're kind of thinking about this. Every one of these compensations is trying to help fix the underlying problem of reduced cardiac output. And each one does that in its own way. But every one of these compensations has a really big negative side effect in that it has a good and a bad. Everything has a good and a bad. So as you're studying these or as you're taking notes, kind of think of, okay, this happens to help fix cardiac output. Why is it good? Kind of how does it help fix that goal? Why is it bad? How does it make things worse for the body? And we'll go through each of those as we go through. So heart failure is a reduced cardiac output. So to understand the compensations, it's good to remember that cardiac output is heart rate times stroke volume. So what can the body do to improve a reduced cardiac output? It basically has two tricks to play with. It can either affect heart rate or it can affect stroke volume. So let's first look at the activation of the sympathetic nervous system. And let's actually take one step back and say why? Why would the sympathetic nervous system become activated with reduced cardiac output? Well, if you have less cardiac output, you're pumping less blood into the peripheral vascular system. Do you guys remember that we have stretch receptors in the walls of our blood vessels, like baroreceptors, for example, that can sense how much stretch is in the wall, and by doing that, they're sensing how much pressure is in the vessels. So if you're reducing cardiac output, you're not going to be pushing as much blood into the blood vessels. There's going to be a lack of stretch, and that will get sent back to the brain and be like, something's not right here. Let's turn on our sympathetic output to try to fix the problem. So as you can see here, with reduced cardiac output, you get activation of your sympathetic reflexes. So if we think about what the sympathetic nervous system does to the heart, right, it will increase heart rate and it will increase contractility. Well, heart rate has to be good, right? Because it's like one of the things that increases cardiac output. Cardiac output is heart rate times stroke volume. So if you can increase the rate of the heart beating, that should help to compensate for this reduced cardiac output. If you can increase the contractility and make the heart actually squeeze harder, try to squeeze more blood out per beat, that can also contribute to an improvement in cardiac output. I'm just going to draw that Frank-Starling curve because we're going to use these to talk about and understand the compensations of heart failure. So on the y-axis, you have stroke volume in milliliters. So kind of right in the middle here is around 50. The x-axis is your end diastolic pressure in millimeters of mercury. So if we go 10, 20. All right, and our normal curve looks kind of like that. Let's write normal on here so we remember. Normal end diastolic volume or pressure is the star here. So I'll just write this up here. So like normal end diastolic pressure is somewhere between 4 and 7 millimeters of mercury. So here we are living on our normal curve, right? This is the Frank-Starling curve. If if you have a sympathetic activation, you can get a little more stroke volume. If you change end diastolic pressure, you can change stroke volume. You can kind of see how you can walk up and down this curve. Now, what happens with stroke volume during heart failure, or I should say, the heart failure causes a reduced cardiac output. Let's draw that into this figure and add a curve to represent this kind of blue normal person going into heart failure. Let me just grab a different color here. So causes of heart failure, like this normal blue person, all of a sudden, let's say they have uncontrolled hypertension, right? They have an increased afterload and they're trying to pump into a higher afterload that's going to limit the amount of blood coming out per beat. Or another example might be they suffered from a myocardial infarction that damaged the wall of their ventricle and now their contractility is low. Whatever the cause, when someone goes into heart failure, this curve is going to shift down. So, this is our new heart failure curve. Someone's gone into heart failure. They've experienced something that's limiting cardiac output, right? There's a huge range of what that might be. Initially, let's say this just started right now. We start heart failure, we drop our curve because something is reducing our cardiac output. Initially, we'd still have the same end diastolic pressure, right? So you could just kind of march down and see where would we be at that moment with the same end diastolic pressure. And by where are we, I'm talking about what's our stroke volume now on this new curve. So you can see that by dropping the curve down, we've reduced our stroke volume. So I'm drawing this on the board because we're talking about the compensations that occur with heart failure. And we said that the sympathetic activation can increase heart rate and increase contractility. So if you're looking at this curve and you're looking at the green curve and we increase contractility, what would happen to that curve? If we can squeeze harder each beat, we should be able to slide that back up. And I'm just going to draw an orange line right on top of where the blue line was to show that we can have heart failure plus SNS, sympathetic nervous system activation. With sympathetic nervous system activation, you can drive the system and actually restore cardiac output at a cost. So right, we're driving our sympathetic nervous system to get us there, but that compensation stimulates the heart to squeeze harder, can or could help to return cardiac output back into a normal range. That's good. But remember, every one of these compensations has a good and they have a bad. The sympathetic nervous system does not only act on the heart, it also acts on blood vessels. And when you have a sympathetic output, that causes vasoconstriction. If the blood vessels in the periphery vasoconstrict, that is going to raise total peripheral resistance. Another way of saying that is that's going to raise afterload. So by activating the sympathetic reflex, you can stimulate the heart to beat faster and harder, but at the same time, you're increasing the resistance in the periphery, increasing the resistance to that pump. So this can help a little bit, but the presence of high sympathetic tone raising afterload is now putting a new strain on the heart. So that's our first compensation, activation of the sympathetic nervous system. So in the space below this diagram, I have them numbered, kind of 1, 2, 3 sympathetic reflexes was first. Let's move on to the second one, which is the renin-angiotensin system. So if you're familiar with the renin-angiotensin system, this is a response from the kidneys, right? When they're not getting enough blood flow, they can release renin. That decreased perfusion pressure sensed by the kidneys is the stimulus for the renin-angiotensin system. The renin ultimately creates angiotensin II, and angiotensin II stimulates the production of aldosterone. So this is often written as the RAS system with 2 A's, the renin-angiotensin aldosterone system, because as soon as you get angiotensin II, you get aldosterone. All right, so the kidney's getting less perfusion pressure. Does that make sense to you already why that might be? If someone's in heart failure and they have reduced cardiac output, why is the kidney seeing reduced perfusion pressure? Lower cardiac output means less blood flow getting to the kidney. So the kidney says, I'm not getting enough blood coming through me. I'm going to stimulate the renin-angiotensin system. And both angiotensin II and aldosterone work at the level of the kidney to increase sodium and water retention. You're hanging on to water, really. We just use sodium as the mechanism because water follows sodium. If you are peeing out less sodium and water, that means you're keeping more in your body. That is ultimately going to increase your blood volume. If you can increase the total volume in the system, this is going to send more blood back to the heart in what we refer to as venous return. If you get more those went together. If you get more blood back to the heart, you will raise preload. So let's look at this again on the Frank-Starling curve. We're going to draw this in here. We have our stroke volume. This is around 50. End diastolic pressure, 10-20. Our normal curve, I'm going to draw it a little longer here, right? In the normal world, we started kind of right about here because normal end diastolic pressure is somewhere between 4 to 7. So this was in our normal state. This is what you and I likely experience for our preload. We get about 4 to 7 millimeters of mercury. Now, we activate the renin-angiotensin system, and it allows us to increase our blood volume, which is going to send more blood back to the heart. What will be the effect on our graph here? Well, if you have more preload, you are going to raise end diastolic pressure. By raising end diastolic pressure, you're going to increase stroke volume. Look at the difference there, right? And this, without changing anything else, we have increased stroke volume because more blood returned to the heart means more blood pumped out of the heart. If you can raise stroke volume, you can help to make up for the deficits of cardiac output, which is the underlying problem with heart failure. So by activating the renin-angiotensin system and increasing the total blood volume, you can increase venous return, elevating your end diastolic pressure to help drive the system to deliver more blood per beat, increasing stroke volume. Because every compensation has a positive and a negative, that is the positive of the renin-angiotensin system. This compensation really kind of has two separate negatives. The first is, if you look at the blue line of the Frank-Starling curve, you see it kind of has this exaggerated linear trajectory, and then it plateaus out at the top. There is a limited benefit to increasing end diastolic pressure because the heart can only stretch so much. You can only put so much blood in the heart during diastole. And you get to a point where any more pressure actually does not get you any greater stroke volume. And this is what we see happening in heart failure. The renin-angiotensin system gets activated, and you get this effect of increasing stroke volume, and we are happy, right? This is good. We have helped to fix the cardiac output problem. But the body keeps holding on to fluid because the cause of the heart failure is still there. And so you hang on to a little bit more. And now you have even greater blood volume, but this is still good, right? We've raised stroke volume a little bit more, right? We can see a difference here. But the renin-angiotensin system is still activated, and you grab onto more fluid. And now all of a sudden we're seeing that this extra fluid is having a smaller and smaller, if almost no effect on stroke volume. So early on, this compensation is effective. And this is like a super effective compensation if you would suddenly have low perfusion. Like if you had a big bleed, your body could hold on to fluid and it's going to march up this line, and this is going to help you. People in heart failure max out this compensation very early on, but the kidney doesn't know that. It's just if the kidney's not getting enough blood, it keeps the renin-angiotensin system around, and you could actually just extend this line, and they keep holding on to more and more and more fluid with no added benefit to stroke volume or cardiac output. So because the Frank-Starling curve plateaus, this benefit only affects them up to a certain point, and then they just start hanging on to fluid, causing their failing heart to handle more blood without any benefit. And then keep in mind, when we thought about some of those symptoms of heart failure, and we talked about fluid backing up in the system behind it. It kind of seemed like a lot of fluid, right? The pictures of people were having, really swollen legs and big ascites in their belly and bulging jugular veins. And kind of like, whoa, where did all this fluid come from? They have so much fluid because their body is hanging on to fluid in the attempt of using the renin-angiotensin system compensation to try to help out with cardiac output. But they likely maxed out that benefit months or years ago. And now their body is just having to handle and hold on to all this fluid with no benefit at all. The second negative of the renin-angiotensin system is the fact that angiotensin II both acts at the kidney to help increase sodium water retention, but it is also a potent vasoconstrictor. So when you activate the renin-angiotensin system, you're increasing peripheral vascular resistance. All right, so now we've got two systems that are both causing vasoconstriction and raising afterload on the heart. The sympathetic nervous system vasoconstricted, and now angiotensin II vasoconstricted. And this can help explain why they continually progress into worse and worse heart failure. Why compensation doesn't just, we held on to more fluid, we fixed the problem, and now we'll just hang out here. Because each compensation has a negative. As they raised stroke volume with fluid, they raised afterload that the heart had to pump into. And then once you get, really late in the game down here, now they're, vasoconstricting and having all this fluid at no benefit. And it really gets worse quickly. The last compensation just kind of is part of all of this, and that is the activation of the Frank-Starling mechanism. The increased volume puts a stretch on the heart, which when you stretch the heart, you increase the contractility. So this is our second mechanism that's increasing contractility. So both the sympathetic nervous system and when you increase the volume, you can activate the Frank-Starling mechanism. So I'm just going to draw this out one more time, kind of telling the story as we go on the chart, kind of putting some things together. So you can just watch this along, or you can draw along with me if you think it's helpful. So we have stroke volume in milliliters and end diastolic pressure in millimeters of mercury. Right, so we go 10, 20, this is around 50. So here's our normal curve where we start. And our end diastolic pressure starts pretty low, right around 4 to 7. So this heart goes into some kind of heart failure that will drop the curve down. We've kind of gone through some of those extrinsic factors that could have happened, acting on the heart, or something within the heart has reduced cardiac output. So our stroke volume has gone down because of the heart failure. So with the reduced blood flow to the kidneys, you can activate the renin-angiotensin system. And the renin-angiotensin system is going to hold on to more blood volume and will actually move our end diastolic pressure up the curve. So our end diastolic pressure is higher, but look at what we've done. We've basically normalized our stroke volume, right? It's in line now with the original purple X. So by holding on to more blood volume, we were able to restore stroke volume. But with the renin-angiotensin system, we get increased afterload. So as you increase afterload, that's actually going to lower the ability to pump blood out, and we're going to shift the curve down again. So kind of heart failure now plus the increased afterload. So we've again lost some of our stroke volume. So what could we do here? Well, the sympathetic nervous system might be able to pop this line up a little bit if we had the sympathetic nervous system activated. The renin-angiotensin system is going to continue to hang on to fluid, so we're going to keep marching up this line. So we're going to increase our blood volume, maybe kick this line up a little bit with sympathetic nervous system. But you can see we've already hit the flat part of the curve here. So any further increase in blood volume is really not going to benefit our stroke volume at all. And in fact, because the sympathetic nervous system is causing vasoconstriction and because the angiotensin II is causing vasoconstriction, at the same time that we're walking up the curve is likely dropping even further. We'll write this as heart failure advanced. So now we are sitting at really high end diastolic pressures. And I'm going to make this a black line so we can follow it all the way over. If we follow this line all the way over, our stroke volume is way down from where we started. It's not able to make up for the difference, even in the face of high sympathetic activation, extra blood volume. There's no longer any of these compensations that are fixing the problem. And this is now, clinical heart failure where someone is going to need intervention because their physiological mechanisms cannot make up the difference. And if we think about, what this is a human heart that's experiencing all of this, right? This human heart is being dumped on with extra fluid. This human heart is being stimulated to squeeze harder and faster every day, day in and day out, day in and day out. So the heart is obviously going to change over time in response to this series of compensations that occur. So let's go back into the PowerPoint and talk about how the heart actually changes over time during heart failure. So there is cardiac remodeling that happens. And at the top of the next page of your notes, you'll see the two main effects listed out. The first is that from repeated stimulation over time, the heart undergoes hypertrophy, specifically ventricular hypertrophy. Increased resistance against the heart has to work harder, and it pumps harder every day. It's going to stimulate that muscle to grow. So as the muscle gets bigger, the walls get thicker, and that's kind of illustrated here, trying to show that the cardiac wall has gotten thicker, which in theory, should be kind of good. More muscle, greater force. But as the walls get bigger, the size of the ventricle gets smaller. Decreased ventricular size. The walls kind of take up the space. So if the size of the ventricle gets smaller, there's less volume to get blood in. If you can't get as much blood in during diastole, that is called diastolic dysfunction. So with cardiac hypertrophy, we see diastolic dysfunction. The problem is in the filling. There's just not enough space. The chamber gets smaller and smaller and smaller. The other thing that happens with cardiac hypertrophy is as the muscle size gets bigger, it is harder for the body to deliver enough oxygen and blood to that big, huge, thick wall. The muscle basically grows faster than the blood vessels. So you've got more muscle per capillary. So once you start seeing cardiac hypertrophy, this can lead to cardiac ischemia because there's so much muscle and not as much blood because the muscle grows faster than the vasculature in this case. And patients can end up having a lot of ischemia. The other compensation that can happen is that with all this increased volume, I like they put a little faucet on here for this, increased volume, you are dumping way more blood back on the heart, right? That whole climbing of the Frank Starling curve was increasing blood volume with every one, like more volume, more volume, more volume. Well, that is over time going to stretch the heart. If you increase preload with every beat, it's going to stretch the heart out. So now we see this big, huge heart, right? But really thin little walls, puny little thin walls. And you lose the length-tension relationship in the wall of the ventricle, which is going to reduce contractility. It's not going to be as strong. If you can't pump as hard, then the problem is during systole. So this is systolic dysfunction. So there are two main classification systems that help to give you clinical information about how, kind of where on this spectrum of the disease your patient is. Because again, chronic failure, heart failure can be months or years, that these compensations are, successful, somewhat successful, less successful, truly failing. And so patients will look very different depending on where they are on those curves. And so classification systems give you information about where they are. And there's two main systems. The ACCF is the American College of Cardiology Foundation, also in line with the American Heart Association. And they classify the heart failure based on objective assessment. So this is an ABCD system, and you can see that it's looking at the structural kind of integrity of the heart. So an A is someone who's just at risk for heart failure. There's nothing structurally wrong with their heart. They don't have any symptoms, but they have some of the causes of heart failure going on. They have uncontrolled hypertension, or they've had an MI. They have something that's put them at risk for going into heart failure. They are stage A. I almost said 8. Stage A. B is when there is something wrong with the heart. There is now a structural evidence of the heart failure, but they don't have any symptoms yet. So B, they have the structural changes, but they haven't yet developed symptoms. So they are early on in those compensations. The compensations are working. Something has affected the heart that would impair its ability to maintain cardiac output, but the physiological compensations are handling it. There's no signs or symptoms. Once you get to a C, now you have the structural heart disease and you have had symptoms. And what's interesting about their classification system, the American Heart Association, it says current or prior. So you never go back. I'm going to put an X through this. You can't be a C and then become a B. Because if you have symptoms and then they start you on a med of some kind that controls your symptoms and you are symptom free, you are still going to be classified as a C because you've had prior symptoms. And that's really different than the New York Heart Association on the right that we'll talk about. So a C, they have the structural heart disease as you would in B, but now they have either have or have had symptoms of heart failure. And then D is refractory heart failure, meaning you're no longer managing the heart failure with the meds. They need some kind of more severe intervention, or the heart failure will kill them at that point. So that's D. The New York Heart Association is based on how limited they are during physical activity. So this is kind of the one that we like a lot as PTs because it's really describing their function. So a classification of a 1 is that they have no limitations to physical activity. Nothing causes the symptoms, they're fine. 2 is when they have slight limitations to physical activity, but nothing at rest. And so it's like the physical activity is what causes it. Once they get to a 3, then it's marked limitation with physical activity, still comfortable at rest, but less than ordinary activity is now causing symptoms. And a 4 is that they really cannot do physical activity and they're having symptoms at rest. So unlike the American Heart Association, the New York Heart classification system, you can move between these, right? Like you can be a 3 and then go through a really good physical therapy program and become a 2, right? And be less symptomatic and be able to do more physical activity. And then maybe the disease progresses and you kind of go back to a 3, but you can move between these stages. So it really reflects what the patient looks like in real time. And I don't mean to say that one is better than the other. The New York is just more applicable to what we really care about when we're trying to make clinical decisions. So it can be helpful. So I just wanted to put this on your radar. I think we mentioned it in the lab values lecture, but there is a lab value that is associated with heart failure. And the gold standard for measuring heart failure is B-type natriuretic peptide, BNP. BNP is released from the ventricles when they're under stretch. So you can see that this is a good measure of heart failure when you're thinking about how the heart is, or what the heart is being exposed to with all these compensations. So when the ventricles are stretched, it releases BNP. So normally you shouldn't have a lot of BNP in your blood. It should be less than 100 picograms per mil. When you get between like 100 and 700, those are people who have chronic chronic heart failure. So chronic heart failure, you would see elevated BNP, but kind of within that range of the hundreds. When you see BNPs above 700, that is someone who is in acute decompensation. They are in acute failure where they're not maintaining cardiac output and they're going to need some intervention. So a lot of times when patients get hospitalized with heart failure, you see very high BNPs reflective of that decompensation. So you guys will talk about the meds associated with this, obviously, in Pharm, but I just wanted to kind of put in the context of the story of heart failure because the treatments really fall into two main categories. They either are drugs that are trying to help the heart increase forward flow, right? They're trying to increase cardiac output. So stimulate the heart to try to boost up cardiac output. Or there's the drugs that are trying to reduce the backup. Because again, the compensation causes all this extra blood and it's not doing them any good anymore. Even though an increased blood volume in normal physiology should increase stroke volume, they have maxed out that benefit and they have way too much volume on the system. And now their failing heart is managing all this extra blood. So there's a lot of drugs that are trying to reduce that backup. So when we think about drugs that are trying to increase forward flow, increase cardiac output, we've got inotropes. Inotropes are drugs that increase contractility. They increase how hard the heart is squeezing. Now, in general, this type of drug is only used when someone is either in acute heart failure or is super end stage heart failure. Like this is the only thing that's going to keep them alive. Because if you are stimulating the heart with a drug, you're actually making the heart work harder. So you can see that there would be times when someone is in a life-threatening position in heart failure that at all hands on deck, just stimulate the heart as much as you can, get as much out of that muscle as you possibly can to keep the patient alive. But that's not a good option for someone who is going to be using this med for a long time because that will be an extra strain on the heart. The second one on the list is to decrease the rate of the contraction, to actually reduce heart failure. And that might feel a little counterintuitive because cardiac output is heart rate times stroke volume. And I'm saying that we could give them a drug that could lower heart rate. So if your kind of warning bells are going off, that's an appropriate response to me telling you we should slow down the heart. So here's some things to think about. The heart is working when it's beating. Right? It's like, again, I always like to put the heart back to thinking about like your bicep because I feel like we're so much more comfortable with peripheral muscles. But if your arm is hanging at the side of your body, the bicep isn't really doing any work, right? But when you lift up the weight and lift the weight and contract it, that's when you're using the ATP. That's when the heart is working. That's when the muscle's working. So during diastole, the heart is at rest, right? It's just a saggy bag letting blood drip into it. When you are squeezing the heart, is when the heart is working. So kind of a mainstay treatment for heart failure is a beta blocker. If you decrease the heart rate, you put more time between the beats and allow greater filling of the heart. So then if you slow down the heart, let it fill more, then when it contracts, you'll get more blood out per beat. So this is a way of reducing the work of the heart while still maintaining cardiac output. So if you allow more time between beats, more blood will get into the heart during diastole so that when the heart contracts, it will have more stroke volume, more bang for your buck. Let's get the most blood out in one beat that we can because the heart is working when it's beating. So beta blockers help to reduce the work of the heart by allowing a greater time to fill between beats. And then drugs that reduce the backup, we have drugs that reduce preload. So they are venous dilators like our nitrates. Diuretics are just the mainstay of treatment. Try to get them to pee this fluid out. Let's block the renin-angiotensin system, right? That's the main system that's holding on to all this fluid. So it's very common to see ACE inhibitors. The ARBs are angiotensin receptor blockers. That will all help. And then the opposite of that is to reduce afterloads. The heart has an easier time pumping forward, which in effect would reduce backup. And that would be arterial dilators. And then again, ACE inhibitors kind of hit two birds with one stone. So that is a big drug in heart failure because you both block the action at the blood volume and you can dilate the arterial system and reduce afterload. So we will talk obviously a lot about heart failure in cardiopulm. So this is not the end of your knowledge of what you'll do with it, but it's also kind of nice right at the beginning to start think about how you're going to treat these patients. And when you guys are on your acute care clinical next fall, when you see heart failure patients, some things to keep in mind. So a really big one is to monitor vitals. Obviously, we should be monitoring vitals in every patient, but heart failure patients are very tricky. Like they're very unstable and things can change quickly. And we often come and we are putting a strain on their heart. Physical activity, PT in general, is going to strain their heart. So we want to really be careful in monitoring what they were like when we came in, their response to activity, and during recovery to make sure that they are handling the therapy well, and that we're appropriately working with them. A really good clinical evidence that we have of how well we can push patients or if we've done too much is to monitor the evidence of that congestion. So we can measure and assess pulmonary edema and peripheral edema. Pulmonary edema we listen for, so we do lung sounds and you can listen for crackles and you can hear the fluid on the lung. So if you think through the mechanisms of heart failure, failure to maintain cardiac output causes fluid to back up in the system. If you walk into a patient's room and you listen to their lungs and there's no fluid on the lungs, they are in a good compensation right now, right? They're in heart failure because they have things that have stressed and strained the heart and caused a problem with their ability to maintain cardiac output. But their compensations are just managing it and there's no fluid in the lung. Then you come in and you have them get up and you do some marching in place and you do some other, ADLs around the room and they're getting a little short of breath and they're getting worn down and you listen to the lung and now there's sounds of fluid in the lung. What have we done? We have overstrained the heart, right? The heart was not able to keep up with what we asked it to and fluid began to back up in the system behind it. So when you see a change, right, there was no edema, now there is edema, that is an overstressing of the heart. Same thing with the periphery. You can measure the amount of pitting edema. You can look at their legs before and after therapy to determine how well they tolerated what you did with them. Anything abnormal, you got to report to the medical team because you might be the first responder because you are the one that's coming in and maybe causing the greatest stress to the heart. It's incredibly important in terms of intervention planning, medication changing, especially around discharge, because if you saw something, you want to report that before they're making decisions on sending that patient home. Positioning can be a really big thing because they have so much fluid. So Fowler's position is what you see on the slide here. It's when you keep the head of the bed 20 inches above the level position or more. And by keeping the heart up, you're keeping some of the fluid off of the lungs and the heart or keeping it all down in the bottom of the lungs so it's not as bothersome, and they'll tolerate therapy better. A lot of heart failure is trying to get the patient in the best position possible to get some benefit from the exercise. If they're laying flat and all that fluid is pouring back on their heart and they're short of breath and they're dyspneic and then you're trying to do therapy, they're not going to be able to do anything. So get them in the best position possible to reduce the amount of blood coming back to the heart so that during therapy, the heart's in the best position possible to handle the exercise. That's similarly with the second one. If you keep the legs in the dependent position, and I'm remembering now, every year, I always forget that you guys aren't familiar with, some of you are not familiar with the dependent position. That's down into gravity. So keeping your legs down, letting gravity to pull the fluid down into your feet means that the blood will stay down and there's less venous return. So patients will tolerate therapy better. So if you're trying to do something in the bed, if you can dangle the legs off the edge of the bed and let blood kind of accumulate in the feet just during therapy, so there's less venous return, they might be able to do more that you're asking them to do. So just kind of thinking through how their position is moving the fluid, how what we're doing is moving the fluid, and how that might impact their ability to tolerate therapy. So that is the end of the heart failure piece. So it's important to understand the general kind of causes of heart failure, the different physical parts of the heart that can be affected, the different parts of the cardiac cycle that can be affected, how that manifests itself as symptoms in the body, and then how the body tries to compensate, and then the overall effects of those compensations over time. So I'll end this video here and pick up the second half of the lecture starting with arrhythmias. Have a great day.